بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل سنة وانتم طيبين بمناسبة شهر رمضان. ونحب نحيي الجمعية طبعا على المجهود الرائع في توصيل المعلومات والمجهود العلمي في شهر رمضان. النهارده هنتكلم على موضوع يعتبر بالنسبة لنا ككارديولوجيست من المواضيع اللي هي إلى حد ما صعبة شوية في التعامل معاها، وهي Microvascular Angina. So by definition, defined as impaired vasodilatation of arterioles leading to an inadequate increase in blood flow from rest to stress. كده القلب ما يقدرش cope with the exercise of the patient and should be characterized by evidence of reduced coronary flow reserve. مشكلة الناس اللي هم عندهم microvascular dysfunction اللي هم يبقى عندهم decrease في coronary flow reserve. That should not be explained by the presence of any epicardial stenosis. There are some facts that 10 to 30% of patients who are referred for coronary angiography has no significant coronary artery disease. من المجموعة اللي هم has no significant coronary artery disease تقريبا 50% ل 65% منهم with chest pain has no obstructive coronary artery disease I believe to have coronary microvascular dysfunction. المجموعة دي they have a poorer prognosis and they have long-term adverse events in comparison to other patients. وبالتالي المشكلة زي ما في معظم الستاديز قالت there is increase in 5-year risk of MACE and also in all-cause mortality. مشكلة الناس ديت ان هم experience recurrent attacks of chest pain بيخليهم يروحوا بشكل متكرر للجي بي او الاي ار، وبالتالي يحصل لهم rehospitalization للchest pain دوت without proper diagnosis and repeated coronary angiography. This chronic chest pain can impair mental health and lead to long-term psychological morbidity وبالتالي poor quality of life. Generally, the microvascular dysfunction are classified into 4 types. Type 1 is the coronary microvascular dysfunction in the absence of obstructive coronary artery disease and myocardial disease. The type 2 is with myocardial disease. Type 3, which is associated with obstructive coronary artery disease, and type 4, which is the iatrogenic type. The first type is our focus in this discussion, بس سريعا كده the other types. Type 2 اللي هو myocardial disease is sustained in most instances by adverse remodeling of intramural coronary arterioles. Type 3 بيبقى occur in context of either stable coronary artery disease or acute coronary syndromes with or without SC segment elevation, and also is very difficult to identify than the first 2 types. Type 4, which is iatrogenic after coronary recanalization and seems to be caused by vasoconstriction or distal embolization زي ما احنا بنشوفه في بعض الناس اللي بيخشوا يعملوا primary PCI. So for type 1 there is multiple pathophysiological يعني بعض الناس اقترحوا بعض الباثوفيسيولوجي ميكانيزمز للبيشنتس دول، بس اللي هو most accepted pathophysiological mechanism is that there is high level of resistance in the arterioles which constitute the dominant site of myocardial flow regulation. This is responsible for coronary autoregulation process and responsible for adaptation to myocardial demand. مع الوقت مع development of atherosclerosis the resistance of coronary arterioles is progressively dishosted. The myocardial underperfusion occurs at complete exhaustion of reserve vasodilatory capacity, leading to myocardial ischemia مع الوقت. الرسمة ديت هي يمكن شكلها معقد شوية، ولكن with all causes of chest pain is cardiac non-ischemic chest pain, non-cardiac chest pain, and cardiac ischemic chest pain. المجموعة بتاعت microvascular angina they lies in this cardiac ischemia with coronary spasm, atherosclerosis, inflammation, endothelial dysfunction, sympathetic dysfunction, smooth muscle dysfunction. All these pathophysiological mechanisms are attributed to the development of microvascular angina. This clinical presentation for these patients are variable. بنشوفهم كتير. They have effort-induced retrosternal oppressive chest pain. هو ischemic chest pain زي ما احنا عارفينه، ممكن يكون معاه dyspnea أو ممكن يجايب just by dyspnea. The symptoms can develop after exercise HSCs، يعني البيشنت يعمل exercise بتاعه عادي وبعد فترة تلاقي البيشنت بعد ما يخلص exercise يحصل له chest pain and it may respond to sublingual nitrates or oral nitrates. Risk factors for this are the female genders more, estrogen withdrawal especially was incriminated in this, smoking and diabetes and hypertension, hyperlipidemia, and also some inflammatory disorders. That are additional risk factors for atherosclerosis. For this diagnosis of this disease, a triad بتاع chest pain, evidence of ischemia, and they should have normal coronary angiography. Okay, for these patients you have go through stress testing after patient بيجي chest pain بتحاول يعمل non-invasive testing, and then you assess the coronary flow reserve either non-invasively or invasively. You can assess the myocardial blood flow by non-invasive methods, the PET or CMR, and also by contrast echocardiography. This flow diagram shows summary for what we want to say about the diagnosis for these patients. So with patients with angina symptoms, you refer them for stress modality, the echo or nuclear studies, and the finding in this, either the patient who has ECG changes and angina without resting wall motion abnormality, أو no ECG أو no resting wall motion abnormality, وده other causes of cardiac chest, other non-cardiac chest pain could be considered. أو لو البيشنت هو عنده equivocal changes في ECG, stress ECG ومعاه resting wall motion abnormalities, you should refer this patient for coronary angiography. In the patient with coronary angiography, you have to assess the myocardial blood flow. لو البيشنت ده عنده coronary stenosis either moderate, mild or absent, ده ليه modality of assessment. لو severe diameter stenosis more than 70%, so this patient is referred directly for revascularization. Whatever the other three, either you have to refer them for FFR أو هيتعمل له acetylcholine test لو هو absent coronary stenosis أو mild coronary stenosis. The FFR, you can see that if 0.8 cutoff point اللي احنا كلنا متفقين عليها, يبقى significant coronary artery disease and the patient could referred for revascularization. أو لو هو FFR more than 0.8, so you can refer this patient for acetylcholine test. The finding in the acetylcholine test, either there is no response or less than 75% diameter reduction, أو no with no angina, no ischemia, no ECG changes, أو لو البيشنت برضو no change in diameter reduction بس في angina وفي ischemic ECG changes, أو البيشنت عنده more than 75% diameter reduction ومعاه angina و ischemic و ECG changes. في الحالة ديت الدياجنوز بتاع البيشنت ديت لو هو البيشنت no diameter change and no ischemia and no change في ECG, she should go the adenosine test to test the coronary flow reserve. If it's more than 2.5, this is true syndrome X. If the coronary flow reserve is less than 2.5, and this is what we mean by microvascular angina, which is insulin-independent dysfunction. There's multiple treatment strategies that have been postulated for these patients. حتى هذه اللحظة ما فيش حاجة significant relief for the patients, okay, and there is no evidence for most of medical treatments. Some drugs showed some benefits, the renin-angiotensin aldosterone blockers, the calcium channel blockers, statins, and nitric oxide modulators. Alpha blockers, the brazosine, with estrogens may help in alleviating the chest pain in this patient. Other drugs that could be used, the beta blockers, وطبعا anti-anginal medications زي النيتريتس والرانولازين والترايميتازيدين may be used in this group of patients. Some drugs still under study, the thiophyllene, the tricyclic antidepressants, and some studies mentions the metformin. في حاجات recent لازم الواحد يعني under study دلوقتي زي spinal cord stimulation and also the external enhanced counter pulsation, but the most important and what we want to stress on is the risk factor controls for this patient: weight reduction, exercise, and quitting smoking, of course. And thank you very much.